the U.S. is the world's medicine chest. So we produce far more drug research, Silicon Valley, all of that stuff. And once you produce the drug, the company, it's like a plane that takes off. There are people who are paying first class and people who are sitting in coach, but everybody gets to the same place. But once the U.S. companies produce those products, they have every financial incentive to sell them, even though they're taking a massive haircut on the price. Now, economists are unanimous that R&D, global R&D, depends on global revenues. So those countries are free riding on our investments in research and development, and there'd be more medicines available to everyone if they were paying U.S. prices.
We're happy to talk about solutions. You know, we do agree with Paul that you need to streamline the FDA, and they do need to get more resources to approve generic drugs and other drugs more rapidly. As Neera has said, we need more transparency about what goes into that price. How much is government research? How much really is that company's research? How much is the marketing? How much is the profit? And we believe that you should tie the pricing of drugs to how much benefit they produce for patients, including whether they forestall a surgical procedure and forestall a hospitalization. Drug companies don't price according to that, how much health benefit drugs get. Because if that were true, you would not get $150,000 cancer drugs or multiple sclerosis drugs that don't cure anyone and prolong life 2 or 3 months. We want innovation. All of us want innovation. That doesn't mean we want sky-high $150,000 drug prices. Those are two separable issues.
Lori Riley.
Yeah. Well, I would challenge the notion that companies aren't willing to pay and be paid based on value. Just yesterday, there was a major deal announced between Aetna and Merck for their diabetes drug, where those drugs will be tied towards value-based outcomes. Amgen and Pilgrim entered into a contract just a few months ago on their new PCSK9s.
As a representative of pharma, would you endorse the idea that we should have all drug pricings be value-based pricing? If you agree, we're on the same side, and I'll move over there.
And add in their price transparency.
I would argue, well, let's get transparency nearer that patients
No, don't go off the value-based pricing. Just answer that question.
I would agree that most the drugs today, Zeke, drugs today, more than any other part of the healthcare system, are in part based on value. We have to do lengthy clinical trials where the safety and efficacy products of our medicines are put to test. 2/3 of all drugs submitted to the FDA have comparator data submitted with them today. We then have to go in front of the payers and demonstrate to them the value that our medicines will provide to them. They don't have to cover our medicines if they don't want to. But I will say
but you
our
have a
system,
monopoly and then set the price.
Let her finish.
We are moving towards a system of value, and a number of our companies have stepped forward and said we're willing to engage in contracts that are focused on outcomes. Is it easy to do? I'll be honest, it's not. And part of the reason it's not is government regulation. Government regulation is stuck in a fee-for-service world, and we're moving towards a value-based system. So I would hope and ask you if you would agree with us that changing some of the current government regulations about how we communicate about our products, what we can do to support patients and ensure they're adherent, are addressed so that we can move more rapidly to that system.
Well, let me first say, I'm not sure whether you answered my question or not about value-based pricing. If you're agreed, it's very hard to see how you could have any drug priced at $300,000 or even $150,000 for a year, because that's way over any value-based pricing. And we have a lot of drugs that are like that. So
See,
let me
you're
call
talking about cost effectiveness, and that's a whole other
that's value-based pricing.
That's not value-based pricing.
I want to remind you that we're in the question and answer section of this Intelligence Squared US debate.
I'm going to ask you for a moment to pretend that you're a billionaire. Your name is Mark Cuban. You're on Shark Tank. And someone comes to you, and they're pitching a new idea. It's a parking app. It'll cost them $100,000. They'll hire some coders, and they'll be on the iTunes store in a year, maybe 2 years tops. There's no barrier to entry, and you can get right out there and start earning money. The next person to pitch you is somebody who has a new idea for a drug. And it's going to cost them, let's say, $50 to $100 million just to get through human clinical trials for the FDA. And then there is an 88% chance that in 10 years, it'll be a flop. Which investment are you going to make? That is the challenge that we're facing. Look, the FDA is the biggest barrier here. It's the barrier in generic drugs. It's the barrier to more innovative medicines. We need to find ways to bring more effective medicines to market less expensively so we can have both incremental and breakthrough innovations and more of all of the above, and then tie them to the performance in the market. Because our biggest problem, as I spoke at the beginning, is not the drug price. It is the illness and the death and the disability that we all grapple with. And so the fact that we have very low Alzheimer's drug spending right now because we have no effective treatments is not a cause for celebration. It should be a cause for alarm. So I agree with Zeke that we need to tie more to value, but so many of our federal regulations prohibit pricing value to value, micromanage who gets what price and who can do what, and that is one of the biggest things standing in front of us, especially the FDA's drug regulations that make it so difficult to innovate and so expensive to innovate. And if we change pricing without changing how we innovate, all we're going to wind up is with fewer drugs. And a drug that you don't have for a serious disease is infinitely expensive because you can't buy it.
Thank you, Paul Howard. The motion again, blame Big Pharma for out-of-control healthcare costs, and here making his closing statement in support of the motion, Zeke Emanuel, Vice Provost and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania.
Let me remind you and Paul, we're not debating the FDA and its regulatory policy. We're not debating government regulation. We're not debating whether we want innovation or not. We all want innovation, and we want cures for diseases like Alzheimer's. We're not here to debate all those things. We're here to debate drug pricing and drugs' outrageously high prices. Remember what I said at the start. Since 2008, drug prices, brand name drug prices, have gone up 164%. Regular inflation in the entire marketplace, 12%. In the last few years, drug prices have gone up 2 or 3 times more than every other segment of the healthcare market. And what's driving that are higher prices by higher profits by the insurance company than any other segment of the marketplace and any other segment of healthcare. They make more profits, 3 times as much as the insurance company, sometimes 7 times as much as other insurance companies. The other side wants you to say, look, we should change the deductibles and the copay so that it's more affordable for people. It may be more affordable for people, but as Neera pointed out, it's hidden in your premiums unless we bring drug prices down. Yes, your deductible when you go buy your medicine will be lower, but your premium will go up unless we take control of drug prices. So we have suggested that it is drug prices driving healthcare costs, and what we need to do is to bring drug prices in line with their health benefit. If they're curative, we don't have a problem paying a real good price for it. But we don't want outrageously high prices for minimal health benefits. We want value-based pricing that ties the health benefit to the price. And that's not what we have today, and that's not where the pharmaceutical industry has been going. It's been going using its monopoly power to get as high prices as it can get, and that's why it's driving high healthcare costs. Vote for the proposition.
Thank you, Zeke Emanuel. And that proposition, one more time, blame Big Pharma for out-of-control healthcare costs. And here making his closing statement against that motion, here making her closing statement against that motion, Lori Riley, Executive Vice President of the Pharmaceutical Research and Manufacturers of America.
Thank you, and thank you for having me tonight. I want to reiterate, drug spending is not the reason why we're seeing large increases in healthcare spending. Over the next decade, we're expected to spend an additional $2.4 trillion on healthcare. That's a lot of money. 15% of that is expected to be as a result of drugs. But in that next decade, it's possible that we're going to see new medicines come to market that for the first time actually treat Alzheimer's disease. We're going to see medicines that add to our war chest of medicines in oncology. The progress that we can make over the next decade is significant, and I would argue it's worth that 15% extra in health spending costs. Why is it worth it? Because today there are millions of patients today that are clinging on hope. They're hoping that our industry is able to bring something to market for a disease that ails them. 2 years ago, I lost my mother to ALS. It's a devastating disease where there is no treatment, there is no cure, and quite honestly, today there is no hope. And for patients, whether they have ALS or Parkinson's or Alzheimer's or cancer, I don't know another solution than innovation progressing in the future. We have done that in HIV/AIDS. We've done it in hepatitis C. And we're now at a point, and we're on the cusp of doing it in many other areas. But we have to have the ability to move on. I think 15% of our healthcare dollar devoted to some of the biggest and boldest advancements we see in healthcare is well worth it. We talked today a lot about prescription drug spending growth. We didn't talk at all about the 85% of health spending growth in every other area of our healthcare sector. We didn't question why the cost of a procedure goes up year after year after year. That's a worthwhile debate to have. I'm not afraid to talk about drug costs, but let's talk about all healthcare costs and how do we get to real solutions.
Thank you, Lori Riley. Your time is up. And that concludes round 3 of this Intelligence Squared U.S. debate, where the motion is blame Big Pharma for out-of-control healthcare costs.
I don't think that we can make judgments based on people's spirit. That'd be a pretty subjective decision to be making. I think we have to have rules that say that we are going to provide good quality care for all people.
But the money may not have been there for her pacemaker or for your grandmother's hip replacement.
Well, and that's absolutely true. And end-of-life care is one of the most difficult sets of decisions that we're going to have to make. I don't want bureaucracies making those decisions, but understand that those decisions are already being made in one way or another. If they're not being made under Medicare and Medicaid, they're being made by private insurers. We don't always make those decisions explicitly. We often make those decisions by just letting people run out of money or making the deductibles so high or the out-of-pocket expenses so onerous that they just can't afford the care. And all we're suggesting, and we're not going to solve every difficult problem in terms of end-of-life care. A lot of that is going to have to be we as a culture and as a society starting to make better decisions within our own families and for ourselves.
David Feinberg, the president and CEO of Geisinger. Please welcome David Feinberg.
Thanks, John. So I'm not a professional debater, so this may be suicide, but I'm going to start by disagreeing with Zeke. Okay? So Zeke is an expert on terminal illness, but hey, I'm a psychiatrist. I'm the expert on behavioral change. So let's talk about behavioral change. We could fix every problem we have in healthcare immediately, 50% of the cost. If we ate right, we didn't use illegal drugs, we drank alcohol in moderation, we wore our seatbelts, we didn't shoot one another, and we prevented adverse childhood situations that we know we can prevent. Overnight, we fixed the healthcare debate. So acute care in America is actually excellent. We've designed our system to do that. And I take really offense by what Robert says, because Robert represented an organization that has showed our country how to do this the right way. Kaiser Permanente, which starts in Oakland, California. Geisinger Health System, which starts in Danville, Pennsylvania, are examples that healthcare reform does not start in Washington, D.C. It starts in communities that are committed to the people that are living there, that understand the problems, and engage in creative and innovative solutions to make things better, so that every patient gets care that's compassionate, safe, dignified, and low cost. So we've done some things at Geisinger. We've sequenced 100,000 people's entire DNA for free. We look at their DNA, and about 4% of those people have medically actionable conditions that we can intervene with before the bad thing happens. And on those cases, there's probably about 4 first-degree and second-degree relatives that are also affected. So that's genetic code. Healthcare is not just about getting to the doctor and getting to the hospital. It's understanding your genetic code and also your zip code. And when we looked at zip codes where we provide care, we have towns like Shamokin, Pennsylvania, where 80% of the kids are on subsidized lunch. The rates of diabetes are 1 in 4 to 1 in 5. Food insecure people with great health care through Geisinger still have measures of blood sugar that are out of control. Guess what happens when we bring those people in and we say to them, here is food, fresh fruits, vegetables, lean meats, legumes. And if you're living in a motel we've got spatulas for you, and we have microwaves and hot plates. We're going to teach you about your diabetes, and we're going to give you and your food, you and your family, this food to eat. Every single patient has had a decrease in their hemoglobin A1C, in their blood pressure, in their weight. If this was a pill, it would be a multi-billion-dollar pill. We can use food as medicine, and it's 100%. If a pill decreases your hemoglobin A1C by 1 point, it gets approved. We've seen patients have decreases in hemoglobin A1C of 4 or 5 points to the normal range. I think together, communities can say, we're going to eliminate type 2 diabetes. And Kaiser has been a star at this. They've been a star at making sure that every patient that comes in, when you go to the dermatologist at Kaiser and you check in, they say to you, Mr. Feinberg, we notice you haven't had your colonoscopy. Can we get that scheduled for you? They're closing care gaps on every single patient, so these primary preventions are saving millions of lives, and they've published that. Now, the question that Shannon says, are these just pilots and can they scale? I got news for you. People call us, people call Kaiser every day. About 10 or 12 years ago, we did the first heart surgery with a warranty. The New York Times said if you had the New York Times called it a warranty. If you had an infection or got readmitted, we didn't charge you extra money. Hey, guess what? Bundles, and we can debate whether they're good or bad, have now spread across the country. So I believe healthcare reform begins with the docs, the nurses, the patients, the moms, the brothers and sisters, the communities coming together, taking care of one another, scaling these great ideas, and making sure that every patient gets the exact kind of care that you'd want for everyone in your family. Thank you very much.
Thank you, David Feinberg. And that concludes round one of this Intelligence Squared U.S. debate, where the motion is the U.S. healthcare system is terminally broken. So, Zeke, hang on one second. I want to pick up a point to keep it in play that Shannon made while it's still out there, that she said that change is going to have to come from the top. And you made an argument in your opening, David, that the change actually has to come from the bottom.
That's right.
So respond to her point on that, then.
You know, when I was at UCLA, we diagnosed the first case of AIDS. We did more organ transplants than any hospital in the United States. We invented Herceptin. Those things don't come from Washington, D.C., right? Those innovations happen in our academic medical centers. They happen in places that try to figure things out differently. And this healthcare reform thing is going to happen the same way. And it's because communities, people like our audience are going to say, you know why we have to do it this time? Because we can't afford not to do it. Because if we don't do it, we don't have money for roads. We don't have money for schools. It's a different day. I think we have a moral imperative to get it right, and I think it's going to get pulled by our communities.
So I have heard a lot about the social determinants of health, which I agree is very important. What I'm curious about is for these private integrated health systems that are clearly making a profit, what are you doing to give money back to the community and to support the 28 million uninsured Americans?
We're giving food. We're giving housing. We're giving health literacy.
The reason I'm stepping in is I don't think you guys are going to disagree about that problem, and our disagreement is really about, is the system broken? And
but I'm going to disagree with one thing. I don't think that having the hospital do that is the right way we ought to be doing that.
So
I mean, that is a Band-Aid on a
Shannon,
social
how does your answer play to the thing that we're arguing here?
It's simply that when healthcare is effectively robbing our state and local and federal governments of the money to be able to provide these kinds of services, to provide education, to provide housing, et cetera, then we have to find a way to extract the money out of the system. We can't just keep the money in the healthcare system and then have it do its little bit for, giving to community services and giving to a little bit to housing.
Hippocrates said food is medicine. Kaiser spends 3% of its entire revenue on giving back to communities and social determinants and building walkways and affordable housing and making sure that there's farmers markets.
Kaiser could have done a lot more.
Because legally it is required to by the federal government under the tax rules, and that's what we're saying. We need major intervention to drive the system in the right direction, make it 4% or 5%, and make it affect everyone in healthcare, and now you'll have the money that we need.
Do you
for
disagree that
social
major
service.
intervention is needed? The term they're using, major intervention.
Major intervention is happening. We're talking about major
But
intervention.
it's
We
not.
agree.
Kaiser
Let
made
me-
$1 billion
can I-
in profit last year.
Can
and
I-
they put
can I-
3% into food?
3% of revenue, that's $3 billion.
Okay,
But
but
wait
they
a second.
kept $1 billion.
Wait, hold it, hold it, hold it. We can't all talk at once.
To follow smart money.
Zeke, hang on a second. We can't all talk at once, so let me sort it out. You'll go first, and then we'll move back to the side. Go ahead, Zeke.
Well, one of the things in business is says follow the smart money, follow where investment is happening. And the smart money in venture capital has shown that over the last, since passage of the Affordable Care Act, investments in improving the American healthcare system, not producing more drugs or devices, but in actually improving the quality of the system and lowering costs, has gone up by 32%. A lot of venture capitalists, as Shannon says, see opportunity in the healthcare system to make it more efficient and get rid of unnecessary care. Yes, they want their cut. But one of the factors is if you make it happen, lots of people are going to save by reducing the costs and improving the quality. Not just patients, but also the federal government, private payers, and others, because the way we care for patients throughout the system will change.
Robbie.
This takes time, and we're at the early stages.
Okay,
But
I'm going to
we've
call
had
time. I'm going to call
investment
time to bring in Robert Pearl.
So you're absolutely right. 32% of almost nothing is not a whole lot of money. The biggest thing right now, show me a hospital that's not expanding, that's not building, that's not buying high-cost technology. These investments are being made, for the most part, in Silicon Valley. I live there, in very expensive systems designed to make a lot of money. It's not being invested in the communities, in the wellness programs. It's not being invested there in the big dollars.
So, Robert, you got to leave Silicon Valley. So I left Beverly Hills and I went to central Pennsylvania. And in central Pennsylvania, we are converting hospitals and getting rid of cath labs and making them multi-specialty clinics that are focusing on primary and secondary care.
Hospital beds are going down in America, a lot. And let me give you an example. When did we reach the peak of hospitalization in America? 1981, we had 170 hospitalizations per 1,000 patients. We're now down to 109 hospitalizations per 1,000 American people. And the fact is, we are getting people out of the hospital. We're closing hospital beds, just contrary to what Robbie said.
The major
I'm going to move on to another question, sir, if you can step up. Thank you very much for your question. If you could tell us your name, please.
What we can do is do things to make markets function more clearly. Ask yourself, when is the last time, do you know how much your blood test costs you? Even out of pocket, it's unclear. The healthcare system will be fixed if we bring more market signals in so that things are working better. And also, we can subsidize people, the 28 million people without insurance. We can give them money to help them buy insurance on the private market. And I'll stop there. Thank you very much for your time. Please vote against Medicare for All if you care about costs, if you care about convenience
You're stretching the
and
time
innovation.
there.
We have a lot of investment from venture capitalists and the smart money developing lots of innovations in areas we have never seen attacked before. Primary care, lots of places like Iora and Village MD and others. Mental health services. We've seen new companies to bring mental health services to people. And as I mentioned, Aspire, end-of-life care and palliative care. Who would have thought 10 years ago you'd have new companies in these spaces to transform the system? Change is happening from below, those new companies, those practices with new ideas. And it's being propelled from above by payers who are saying, we need to adopt those things, and we're going to pay you differently. More and more health systems are being at risk, and they're going to change how they pay their doctors to be at risk so that they have a stake in the finances as well as the quality. That's happening in the private side. It's also happening through Medicare. Robbie says, oh, MACRA's so complicated. It is complicated, but the fact is people have two choices. Both choices, whether they go with MIPS or they go with alternative payments, force them to now be cost conscious, to actually be efficient, to get rid of unnecessary care, and to improve their quality. That's the direction of the future. Yes, Robbie says it starts in 2021. That's 10 years before 2030, last I looked, and that means we will have one of the world's best healthcare systems by 2030. Is that too late? We will have squandered a lot of money, all of us agree. But it does mean we can transform. Now, let me conclude with one element why I am wildly optimistic about the American healthcare system. It's called the Judgment of Paris. In 1976, there was a battle over the best wines, California versus France, in Paris, France, with 9 out of the 12 judges being from France. California won. California used to produce junk wine, and then it became the world's best. The American healthcare system is going to be exactly like California wine. We're mediocre. Soon we're going to be the world's best.
Thank you, Zeke Emanuel.
I've been reading a lot of the email questions that we've been getting online. They've been saying the Mayo Clinic is exactly the point. They're doing it. Private industry is doing it. Private hospitals are doing it. The Safeway company is taking action. Why get the government involved in something that is being done already in the private sector, and with the right initiative and impetus could be done in the private sector without government involvement?
You just said with the right initiative, and unfortunately, that initiative hasn't been forthcoming.
That initiative hasn't been forthcoming in the private sector because government has killed it. The Mayo Clinic provides high-quality, coordinated care, but the federal government actually penalizes doctors and hospitals if they follow that model.
Government, whether you like it or not, is going to already be involved.
So much for all ideas being on the table.
We pay for Medicare, we pay for Medicaid. There are a whole host of rules, both at the state and federal level, governing how health care is administered.
That's exactly the problem, and it's why President Obama's approach to healthcare reform is going to fail. He's going to layer even more government rules and more government regulation on top of our healthcare sector, which is going to make it harder for doctors and hospitals to provide high-quality, affordable care.
Doctors are not going to be working for the government. They're still going to be working for themselves.
I think a lot of doctors already feel like they work for the government. The government pays half of all medical bills in the United States, and under President Obama's reform plan, the government would be paying even more doctors' salaries.
Medicare for All cannot repeal the law of supply and demand. Good intentions can't fund hospitals, pay doctors, eliminate waiting times, and ration care. Just ask Canadian crooner Michael Bublé, who's from Vancouver, as I am, and you'll find out. When his son Noah, age 3, was diagnosed with liver cancer, Michael Bublé did not stick around in Vancouver. He went to UCLA and took his son, where he says he had the best doctors there. His son today, Noah, is cancer-free. Most Canadian patients aren't so lucky. Several years ago, my own mother died of colon cancer after doctors ordered her as a senior to wait for a colonoscopy because there were too many younger people on the line who were going to have longer lives, and so she was denied that. She died 2 weeks later from metastasized colon cancer. My family's experience with single payer is not unique. Countless families in Canada and the United Kingdom have stories like mine. We can't bring our loved ones back, but we can take action to save others from similar fates. We can stop single payer from taking root in this country. We can say no to the false promises offered by politicians about Medicare for All. And you can do your part right here, right now, by joining me in voting against the resolution. Thank you.
Thank you, Sally Pipes. And that concludes our closing statements, where our resolution is replace private insurance with Medicare for All.